The next topic is cardiac arrhythmias, which is one of the commonest presentations in the emergency department. Um, Over here, I've drawn two action potentials. One of them is from the pacemaker, which is the SI node or the AV node, and the other one is from the cardiac myocardium. If you can see in both of them, you see that there are essentially three ions which are important in any action potential. There's sodium, there's potassium, and there's calcium ions. The sodium ions are important when it comes to the action potential in the myocardium, and while in the pacemaker, the calcium and the potassium ions are important. And that's why, if you remember, that we have a class of antiarrhythmic drugs which solely deal with calcium, and they're called as a calcium channel blockers, which are a class 4. There is a difference between these two, and the difference comes to this one, where in a normal myocardium, the resting membrane potential, that means the potential where the membrane is at rest, the inner part of the cell is negatively charged and the outer part is positively charged, because the outer bit has got lots and lots of sodium in it, and so therefore it has an abundance of positive ions on the outside, while on the inside we've got the negative ones. And this difference between the inner and the outer parts is called as a transmembrane potential. The normal resting transmembrane potential in the myocardium is minus 90. And when that's the case, the sodium channels, they open, and so therefore the sodium which is present in abundance outside, it rushes inside the cell. And as it comes inside, then it changes from negativity to positivity. And as it changes from negativity to positivity, when it reaches about 60 millivolts, that's where the fire, the trigger occurs in the transmembrane, and this leads to an action potential, and hence there is contraction of the muscle. And this is simulated here on an ECG. The P wave, it simulates where the atria contract, and this is where the action potential takes place on the atria, and followed by a pause, which is the PR interval, and then you've got the QRS complex. And this again is the Q wave, the R wave is the depolarization wave, and this is the depolarization wave. So anything which is going up is the depolarization one, and the wave that is coming down is called as a repolarization. And the repolarization is where the polarity, it comes back to what it was before the start of the action potential. So at minus 60, which is the threshold, you've got the depolarization, and that's where comes the P wave. And then you've got the R wave, which is this one. And then there comes a pause, and which is the QT interval, and that's where the calcium comes in order to sustain the action potential, followed by a fall, and that's where the potassium leaves the cell, and hence you get a positive T wave. Now, if you recall, in patients who've got hyperkalemia, you get tall and tented T waves, and these are the patients who've got potassium in abundance in the on the outside of the cell, and this often leaks from within the cells. 98% of all potassium, that's about 3 to 4 moles of all potassium, is inside the cells, and primarily in the muscle cells. So when it leaks out, it causes a problem with the transmembrane potential, and hence you get a positive T wave, and this is where you get tall tented T waves. When you got in abundance, you've got potassium ions, and then followed by a phase 4, and this phase 4 is where actually the sodium once again starts to build up inside the cell. The difference between the pacemaker and between the myocardium is that you don't see any sodium going in, but you see calcium going in, and the transmembrane potential is actually lower than the transmembrane potential. So I beg your pardon, the transmembrane is higher as compared to the transmembrane potential in the myocardium. So this is minus 70, and the threshold potential likewise is minus 40. But this graph, it's a slow graph, and this is the most important thing when it comes to a pacemaker, that the firing is sustained and the firing is slow. And so therefore that's where calcium comes in. And once again, when it reaches a nadir, then you get the potassium which goes in, and so therefore brings down the transmembrane potential to minus 70 ultimately. The antiarrhythmic drugs, they act similarly in the same way. There are two kinds of arrhythmias: bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias usually means that you need to pace. You need a pacemaker. But tachyarrhythmias, they can be of different types. You've got tachyarrhythmias rising from the atria. They can be rising from the nodes. They can be rising from directly from the ventricles. They can be life-threatening. They can change their shape in one way or another. The whole idea behind treating the tachyarrhythmia is you limit the rate first of all. You need to bring the heart rate down. If the heart is racing, it's not good because it may lead on to heart failure, and obviously cardiac arrhythmias, further cardiac arrhythmias like ventricular arrhythmias. So you need to bring the heart rate down. There are two ways of bringing the heart rate down. One of them is by giving a beta blocker, which is a stimulant. So you need to give a beta blocker in order to curtail the stimulation on the heart, and the other one is that you give them a calcium channel blocker. And the calcium channel blockers will block the transmission of electrical current from the atria to the ventricles by blocking the key AV node. The class 4 drugs are the calcium channel blockers, which are diltiazem and verapamil. We know they can cause a significant reduction in heart rate. Of the different classes, class 1 drugs are those which are called as they're called as the sodium channel blockers. And the sodium channel blockers are the ones like quinidine, procainamide, disopyramide. These are the ones which block the influx of sodium inside the cell. And obviously, as they do that, there will not be any action potential generated because of these blockers. Then you've got class 2, the beta blockers. We've already discussed. They are the rate limiting drugs. Beta blockers, they stabilize the membrane by doing that, and they obviously block the action of adrenaline and noradrenaline on the heart muscle. The third drugs are the class 3 drugs. These are usually like the first line drugs. After you've given them a rate limiting drug, the next one is that you give them one of the class 3 drugs, which are the potassium channel blockers. And these potassium channel blockers will prevent the exodus of potassium from within the cell to outside. And these are the cells like amiodarone, is very commonly used. They're given in order to stabilize the heart rhythm. The class 4 drugs are the ones which call blockers. So in summary, if you get somebody with a cardiac arrhythmia and you see them in the emergency room, check their blood pressure, make sure that the vital signs are all right, and they don't need urgent or immediate cardioversion if they're becoming hypotensive or there are any features of them going into further aggravated arrhythmias. So you first of all limit the rate. You can do that by giving a beta blocker orally or intravenously. It really depends. And secondly, once you've done that, then you can give one of the class 3 drugs, amiodarone, as I said, is often used, and that is used intravenously in a loading dose followed by a regular dose. Calcium channel blockers are often used intravenously, orally, especially in case of supraventricular tachycardias, where you want to block the transmission and you want to control the rate. But calcium channel blockers will not change the supraventricular tachycardia into a normal rhythm. For that, you will often require one of the class 3 drugs. Thank you.